That glass of water you swallow your morning pills with every single day. You trust it, you depend on it. You've been told it's keeping you healthy. But what if the very routine your doctor set up for you years ago is now quietly doing the opposite? I want you to stop for a moment. Think about every pill you took this morning. The one for your joints, the one for your stomach, the one for your blood pressure, the one for your sleep. Now ask yourself a question that most doctors never ask you. When was the last time anyone looked at all of them together at the same time and asked whether they are still right for the body you have today at this age, with the arteries and kidneys and cardiovascular system you have right now? If you can't remember, or if the answer is never, then the next 30 minutes could be the most important health conversation you've had in years. My name is Dr. Richard Calloway. I practice internal medicine and geriatric cardiology for 31 years. I've sat in more hospital rooms than I can count, holding the hands of patients who had done everything their doctors told them, who had taken every pill on schedule, who had never missed a refill, and I watched their hearts fail anyway. Not dramatically, not in ways anyone predicted, but steadily, invisibly, under a kind of cumulative strain that nobody had bothered to connect to the cabinet full of medications on their bathroom shelf. I retired from clinical practice 3 years ago, and the reason I'm sitting here talking to you today is because of something that happened in my last year of practice that I have not been able to stop thinking about. A woman came to see me, 73 years old. Her name was Patricia. She'd been managing her health carefully for 2 decades. Blood pressure medication since her 50s, an anti-inflammatory for her hip, a stomach acid pill she had started taking in 2009 and never stopped, a mild sleep aid she used 3 or 4 nights a week. She walked every morning. She cooked real food. She was not careless. She was not neglectful. By every standard measure, Patricia was doing things right. She came to me because she had been feeling what she described as not quite right for several months. Mild fatigue, occasional heart flutters, some ankle swelling she assumed was just aging. Her prior physician had done a standard workup. Labs looked acceptable. EKG was unremarkable. She was told she was fine for her age. I reviewed her medication list for the first time as a complete picture, not one drug, all of them together. And what I saw was not a list of helpful medications. It was a map of layered cardiovascular strain that had been building for years without anyone connecting the dots. Within 6 weeks of making targeted adjustments, not removing all her medications, but adjusting timing, dosing, substituting 2 of them with safer alternatives, Patricia's ankle swelling resolved. Her resting heart rate dropped 9 beats per minute. Her energy, by her own description, returned to something she hadn't felt since her late 60s. She looked at me during her follow-up and said, "Why didn't anyone do this years ago?" I didn't have a good answer. And that question has followed me into retirement and brought me here. Today I'm going to walk you through something your doctor may not have time to cover in a 15-minute appointment. I'm going to talk about 6 medication categories that are incredibly common in adults over 60 that carry cardiovascular risks that change and often increase as your body ages. I'm going to explain exactly why aging changes the way medications behave inside your body. And I'm going to give you a practical framework, a real conversation tool that you can bring to your next medical appointment to begin a medication review that could genuinely reduce your cardiovascular risk starting this month. This is not about fear. Fear paralyzes. This is about information. Information gives you options. And at 60, 65, 70, options are everything. If this is your first time watching this channel, welcome to Heart Truth After 60. We exist for one reason: to give older adults the cardiovascular information that gets lost in rushed appointments, complicated medical language, and a healthcare system that treats aging as a series of separate problems rather than one interconnected body. Subscribe now, turn on notifications, because what we cover here belongs in every home where someone over 60 is managing their health. Now let's get into it. And I want to start with something that will reframe everything that follows. Because before we talk about specific medications, you need to understand what happens to your body's ability to process them as you age. Because this is the part that changes everything. At 45, your kidneys filter your blood at close to full efficiency. They clear medications from your system at the rate the pharmaceutical trials that established dosing guidelines were largely designed around. At 45, your liver metabolizes drugs with robust enzyme activity. At 45, your arteries retain a degree of elasticity that allows them to absorb and compensate for blood pressure fluctuations. At 45, your autonomic nervous system, the network that regulates your heart rate, your blood pressure, and your vascular tone, responds with precision and recovers quickly. By 70, all of that is changed. Not catastrophically, not suddenly, but measurably, consistently, and in ways that alter how medications behave inside you. Kidney filtration rates decline on average 1% per year after age 40. By 70, many otherwise healthy adults are filtering blood at 60 to 70% of their earlier capacity. This means drugs that are cleared through the kidneys stay in your bloodstream longer than intended. Longer circulation time means prolonged effects. And prolonged effects from a cardiovascular medication or from a medication that has cardiovascular side effects can mean sustained blood pressure elevation, sustained fluid retention, or sustained heart rate increase. Your liver's enzyme systems, particularly the cytochrome P450 family, responsible for metabolizing dozens of common drugs, become less efficient with age. Medications that were intended to peak and clear within 8 hours may now linger for 12. This creates a biochemical overlap effect where you take your morning pill before yesterday's dose has fully cleared. Day after day, week after week, your arterial walls, even without significant disease, stiffen progressively with age. This is called arterial sclerosis, and it is distinct from atherosclerosis, which is plaque buildup. Arterial sclerosis is a universal aging process. Stiffer arteries mean that when blood pressure rises, even temporarily, even modestly, the system has less flexibility to absorb that stress. The pressure spike that a 45-year-old's arteries barely notice can produce significant shear force against the inner walls of a 72-year-old's vessels. And it is that repeated shear force over years that destabilizes plaque, damages endothelium, and increases clot risk. And then there is polypharmacy. The average adult over 65 in this country takes between 4 and 8 prescription medications daily, plus over-the-counter drugs, plus supplements. Each of those substances was evaluated in clinical trials largely designed around single drug use in populations that were often younger and healthier than the average older adult taking them. The interaction effects, the cumulative cardiovascular load of 4, 5, 6 drugs operating simultaneously in an aging body is territory that clinical trials have barely begun to map. This is not a conspiracy. This is a complexity problem. And the burden of navigating that complexity has by default fallen onto patients like you, who often don't have the biochemistry background to know which questions to ask. That changes today. Let's talk about the first medication category. And I'm going to start here because it affects more adults over 60 than almost any other drug class. And because its cardiovascular risks are among the most consistently documented and consistently underestimated. I'm talking about NSAIDs, non-steroidal anti-inflammatory drugs. Ibuprofen, naproxen, diclofenac, celecoxib. They sit in your medicine cabinet. They sit on drugstore shelves in bulk containers. They are the first thing most people reach for when arthritis flares, when a back goes out, when a knee aches through the night, and for a brief occasional use in a healthy person, they serve their purpose. But here is what happens in the cardiovascular system of an adult over 60 who takes these drugs regularly, meaning several times per week or daily for months or years. NSAIDs inhibit an enzyme called cyclooxygenase, specifically two forms, COX-1 and COX-2. This inhibition is how they reduce pain and inflammation. But COX enzymes also regulate prostaglandins that play a critical role in vascular health. When you suppress these prostaglandins, several things happen simultaneously. The kidneys retain sodium and water. That fluid retention raises blood volume. Higher blood volume means higher blood pressure. Your body's natural production of prostacyclin, a compound that keeps blood platelets from clumping together, is reduced. Simultaneously, thromboxane A2, a compound that promotes platelet aggregation and vasoconstriction, continues to be produced. The balance tips toward clotting and constriction. In a 2017 meta-analysis published in the British Medical Journal, examining more than 400,000 patients, researchers found that all non-aspirin NSAIDs were associated with increased risk of acute myocardial infarction. The risk was present at any dose. It appeared within the first week of use, and it was most pronounced in adults who already had cardiovascular risk factors. The risk was not theoretical or statistical noise. It was clinically meaningful, particularly in older adults. Now, I want to be precise here because I am not telling you to stop your medication without medical guidance. What I am telling you is this: if you are taking an NSAID daily or near daily for chronic pain and you are over 60, that habit deserves a serious conversation with your physician. Because the risk profile that justified the original prescription may look different today than it did when the prescription was first written. What should that conversation cover? Ask your doctor about topical diclofenac gel. Multiple clinical trials have shown it provides comparable pain relief for knee and hand arthritis with dramatically less systemic absorption and correspondingly lower cardiovascular risk. Ask about physical therapy. I know it sounds like I'm telling you to exercise your way out of structural joint damage, and I understand that can feel dismissive, but targeted physical therapy, specifically designed to reduce load on damaged joints and strengthen the surrounding musculature, has produced sustained pain reductions that reduce or eliminate NSAID need in a meaningful percentage of patients. Ask about low-dose acetaminophen. It carries its own risks at high doses, primarily hepatic, but its cardiovascular risk profile is significantly better than NSAIDs for many patients. The key is dose monitoring. Ask about capsaicin cream for peripheral joint pain, and ask about the timing of your NSAID use. If you take it daily out of habit rather than in response to active pain, you may be exposing yourself to cardiovascular risk on days when your pain doesn't actually require it. I had a patient named Vincent, 68 years old, retired electrician, took naproxen twice daily for lumbar arthritis. His blood pressure had been creeping upward for 2 years. His primary care physician had been incrementally increasing his blood pressure medication to compensate. Nobody had connected the two. When I identified the NSAID as a likely contributor, and we transitioned Vincent to topical treatment plus structured physical therapy, his blood pressure dropped enough over 8 weeks that his cardiologist was able to reduce his antihypertensive dose. He had been unknowingly using one medication to partially counteract the cardiovascular effects of another for 2 years. That is polypharmacy in action, and it is more common than most patients realize. Now let's move to the second medication category, and this one surprises people more than almost anything else I cover, because it involves something that seems entirely unrelated to the heart. Proton pump inhibitors, PPIs, omeprazole, esomeprazole, lansoprazole, pantoprazole. These are among the most prescribed medications in the world. And for good reason. They are remarkably effective at reducing stomach acid. For patients with active ulcers, severe reflux disease, or on long-term aspirin therapy that requires gastric protection, they have a clear and important role. But here's the reality of how they are often used in adults over 60. Many people start a PPI during a period of acute need, perhaps during antibiotic treatment, perhaps during a course of NSAIDs, perhaps after a stressful period. The acute need resolves, the PPI prescription continues. Months become years, years become a decade, and the patient, their pharmacist, and sometimes their physician stops questioning whether it is still necessary. What does this have to do with your cardiovascular system? Two mechanisms are relevant here. The first involves nitric oxide. You may have heard this molecule mentioned in relation to beet consumption and arterial health. Nitric oxide is produced by the cells lining your blood vessels, and it is one of the primary signals for vascular relaxation. When nitric oxide production is robust, your arteries dilate appropriately, blood pressure is naturally modulated, and endothelial health is maintained. Research has suggested that long-term PPI use may impair the enzyme systems responsible for nitric oxide synthesis in vascular endothelium. The clinical implication is reduced arterial flexibility and modestly elevated blood pressure over time. The effect is subtle in any given month. Over a decade, it is not negligible. The second mechanism is magnesium depletion. PPIs reduce the absorption of dietary magnesium across the intestinal wall. Magnesium is not a minor electrolyte. It participates in over 300 enzymatic reactions in the body. From a cardiovascular standpoint specifically, magnesium is essential for maintaining stable heart rhythm. Low magnesium is directly associated with increased risk of atrial fibrillation, ventricular ectopy, and prolonged QT interval, all of which increase stroke and cardiac event risk. The FDA issued a warning about PPI-associated hypomagnesemia in 2011. That warning has not translated into routine magnesium monitoring for the millions of adults taking PPIs daily. A large observational study published in PLOS ONE examining over 2 million patients found that long-term PPI use was associated with a 16% increased risk of cardiovascular events independent of other risk factors. The authors were careful to note the observational limitations, but the biological mechanisms are plausible. The association is consistent, and for an older adult already managing cardiovascular risk from multiple angles, adding even a modest additional contributor deserves evaluation. What should you do with this information? If you have been taking a PPI for more than 2 years and you cannot clearly articulate why it is still necessary, Ask your doctor to help you evaluate whether a trial reduction is appropriate. For many patients, particularly those whose initial indication has resolved, a supervised gradual taper combined with dietary modifications can eliminate the need for daily PPI use. Ask to have your magnesium level checked at your next blood draw if you have been on a PPI long term. And if you do continue PPI therapy for a valid clinical reason, ask whether magnesium supplementation under monitoring is appropriate for you. I am not asking you to stop your acid medication today. I am asking you to apply the same scrutiny to it that you would apply to any drug that affects your cardiovascular system, because it does. The third medication category I want to address is one where I need to be particularly careful, because the medications themselves are often genuinely necessary, and the risk is not in taking them, but in taking them in the wrong combination, without the right monitoring, or without the regular reassessment that aging bodies require. I'm talking about certain blood pressure medications, specifically the interaction between multiple antihypertensive agents and the physiological changes that come with aging. High blood pressure is a major cardiovascular risk factor. Treating it saves lives. I want to be completely clear about that. But here's a phenomenon I observed repeatedly in older patients that is worth understanding. As adults age and arterial stiffness increases, blood pressure becomes more variable. The difference between a morning reading and an afternoon reading, between a sitting and standing measurement, becomes larger. Arteries that are stiffer don't buffer pressure fluctuations as well. In this context, the goal of blood pressure treatment in an 80-year-old is not the same as in a 55-year-old. Overtreating blood pressure in an older adult, pushing it too low, can cause cerebral hypoperfusion, meaning not enough blood reaching the brain, leading to dizziness, cognitive fog, falls, and in serious cases, watershed strokes. There is a phenomenon called orthostatic hypotension, where blood pressure drops significantly upon standing. In older adults on multiple antihypertensives, this is not a rare complication. It is a common one, and it is responsible for a staggering number of falls, fractures, and hospitalizations every year. The question for anyone over 70 on multiple blood pressure medications is not just, is my blood pressure controlled? It is my blood pressure consistently, stably controlled across different times of day and different positions? Because the swings matter as much as the average. Ask your doctor to check your blood pressure both sitting and standing, particularly if you have ever felt dizzy upon rising. Ask whether any recent lifestyle improvements, including dietary changes, exercise, or weight loss, might justify reevaluating whether your current medication doses remain appropriate. And consider home blood pressure monitoring, not just for high readings, but for the pattern of variability across your day. The fourth medication category I want to discuss is one that generates significant controversy. And I want to approach it with the nuance it deserves. Sleep medications. Benzodiazepines and Z-drugs. Temazepam, diazepam, zolpidem, Zaloplan. Sleep is non-negotiable for cardiovascular health. During deep sleep, blood pressure drops, inflammatory markers decrease, and the heart operates at its lowest workload of the day. Chronic insomnia is itself a cardiovascular risk factor. So I am not dismissing the importance of treating sleep disorders in older adults. But here's what the research consistently shows about sedative sleep medications in people over 65. These drugs work by enhancing GABA receptors in the brain, producing central nervous system depression that promotes sleep onset and maintenance. In the process, they also depress respiratory drive. In younger adults with healthy respiratory systems, this effect is minimal. In older adults, particularly those with any degree of sleep disorder breathing, even undiagnosed, this respiratory depression can cause intermittent hypoxia during sleep, brief but repeated drops in blood oxygen level that the sleeping person never consciously experiences, but that place significant stress on the cardiovascular system. Repeated nocturnal hypoxic events are associated with increased risk of hypertension, cardiac arrhythmias, and in people with existing coronary artery disease, increased risk of overnight cardiac events. This is the same mechanism that makes untreated sleep apnea a cardiovascular risk factor. Sedative medications can amplify an existing mild respiratory vulnerability into something clinically significant. Beyond respiratory effects, benzodiazepines alter autonomic balance. The regulation of heart rate variability, an important marker of cardiac health, is impaired by these drugs. Studies have shown that long-term benzodiazepine users have measurably reduced heart rate variability, a finding associated with increased cardiac risk. And then there is the indirect cardiovascular risk. Falls. An older adult who falls in the night, whether going to the bathroom or simply shifting in bed, and sustains a hip fracture, is entering a cascade of events that carries significant cardiovascular mortality. Immobility after fracture promotes deep vein thrombosis. Surgery carries anesthetic cardiovascular risk. Prolonged hospitalization is associated with deconditioning and infection. The cardiovascular consequences of a sedative-related fall can be profound and entirely non-obvious in terms of causation. What are the alternatives? Cognitive behavioral therapy for insomnia, called CBTI, has the strongest evidence base of any treatment for chronic insomnia, including medication. It is not a brief intervention. It requires weeks of work, but its effects are durable in a way that medication effects are not, and it carries no cardiovascular risk. Ask your doctor for a referral to a sleep specialist or a psychologist trained in CBTI before assuming that long-term sleep medication is your only option. Low-dose doxepin at doses of 3 to 6 milligrams has a better safety profile in older adults than benzodiazepines for sleep maintenance. Melatonin, while not effective for everyone, carries minimal cardiovascular risk. And for some patients, addressing the anxiety or pain that is disrupting sleep, rather than sedating over the symptom, produces more sustainable results. Now I want to address the fifth category and then move into the practical framework I promised you, because I want to make sure you leave today with something actionable. The fifth category is antihistamines, specifically first-generation antihistamines. Diphenhydramine, the active ingredient in Benadryl, in Unisom, in the PM versions of Tylenol, Advil, and dozens of other nighttime formulations. These drugs are so ubiquitous, so easily available, so casually used that most older adults don't think of them as medications with meaningful risk at all. But here's what they do in the cardiovascular systems of older adults. Diphenhydramine has significant anticholinergic activity. Anticholinergic drugs block the neurotransmitter acetylcholine, which plays a critical role in parasympathetic nervous system function, the calming, restoring branch of your autonomic nervous system. When you block parasympathetic activity, sympathetic tone, your fight or flight nervous system becomes relatively dominant. Heart rate increases, blood pressure may rise, and in patients with any degree of coronary artery disease, increased sympathetic tone increases myocardial oxygen demand. But beyond the acute effects, long-term cumulative anticholinergic exposure has been associated in multiple large studies with increased dementia risk and accelerated cognitive aging. A landmark study published in JAMA Internal Medicine in 2015, following over 3,400 older adults for more than 7 years, found that cumulative anticholinergic drug use was significantly associated with increased dementia risk, with some commonly used antihistamines among the highest scoring contributors. For an adult over 65 who takes a diphenhydramine containing sleep aid 3 or 4 nights a week, the cumulative anticholinergic exposure over months and years is not trivial. The appropriate response here is straightforward. If you are using diphenhydramine for sleep, it is one of the drugs most worth discussing with your physician as a candidate for replacement with lower risk alternatives. If you use it occasionally for allergies, that is a very different risk calculation than nightly sleep use. Context, dose, and frequency are everything. Now, I promised you a practical framework, and I want to deliver it in a form that you can actually use, not just hear and then forget. Here's what I call the cardiovascular medication audit. It has 5 steps, and I want you to do this before your next medical appointment. Step 1, gather everything, not just your prescription bottles, every supplement, every over-the-counter medication, every vitamin, every sleep product, every antacid, every pain reliever, everything that goes into your body other than food. Put them all on a table. Step 2, for each item, write down 3 things: what condition it is treating, when it was originally started, and by whom. When anyone last asked whether it was still necessary. You may find that several items on that table were started for conditions that have since resolved, or started by a physician you no longer see, or continued simply because refills kept arriving and nobody ever stopped to ask whether they should. Step 3, identify the high priority review candidates. NSAIDs taken more than 3 times per week, any sedative sleep medication, any first-generation antihistamine used regularly, any acid suppression medication that has been continuous for more than 2 years, any medication that was added in the past year if your cardiovascular health has changed in the past year. Step 4, for 7 consecutive days, measure your blood pressure morning and evening. Write every reading down. Measure it both sitting and after standing for 1 full minute. Note any dizziness on standing. Bring this record to your appointment. It is worth more than a single in-office reading. Step 5, schedule a medication review appointment. Not a regular visit where medication discussion is an afterthought. A specific appointment whose stated purpose is reviewing your complete medication list in the context of your current cardiovascular health. If your primary care physician does not have time for this, ask for a referral to a clinical pharmacist or a geriatric medicine specialist. These reviews have been shown in multiple studies to reduce adverse drug events and hospitalizations in older adults. Now I want to address something I know is running through the minds of many people watching this. You might be thinking, if I start questioning my medications, my doctor is going to think I'm being difficult. Or, what if I reduce something and my condition gets worse? These are valid concerns, and I want to respond to them directly. You are not being difficult when you ask for a medication review. You are being a responsible patient. Every evidence-based guideline for geriatric care recommends regular medication review in adults over 65. You are not asking your doctor to abandon their clinical judgment. You are asking them to apply it to your complete picture, including how your body has changed since any of these medications were first prescribed. As for the concern about worsening conditions, that concern is exactly why you do this in partnership with your physician, not unilaterally. The goal is not to eliminate all medication. The goal is to ensure that every medication you take is still earning its place in your regimen, given your current age, your current physiology, and your current cardiovascular risk profile. Medications are reevaluated in oncology, they are reevaluated in psychiatry, they are reevaluated after every hospitalization. There is no clinical or logical reason why an older adult's long-term daily medications should not receive the same systematic scrutiny. Let me close today with something personal. In 31 years of practice, the moments I am proudest of are not the dramatic interventions. They are not the emergencies managed, the surgeries facilitated, the acute crises resolved. The moments I am proudest of are the quiet ones. The appointment where I sat down with a patient, went through their medication list carefully, made 2 small changes, and watched them walk out of my office 4 weeks later looking 10 years younger in their energy and their clarity. Those moments were not complicated. They didn't require advanced technology. They required time, attention, and the willingness to ask whether what was working 5 years ago was still the right approach today. You deserve that kind of attention. Your body deserves that scrutiny. And the heart that has been beating for 60 or 70 years without a single day off, that remarkable, tireless organ deserves to have every avoidable burden removed from its path. You are not powerless here. You are not at the mercy of whatever was prescribed. You are an informed adult with the ability to ask the right questions, to gather the right information, and to have the right conversation. Start this week. Gather your medications. Write down your blood pressure readings. Schedule the review. Have the conversation. Because prevention at 65 is exponentially easier than recovery at 75. And your heart, right now, in this moment, is asking you to take it seriously. Thank you for being here today. If this conversation gave you something useful, something that changes how you think about the relationship between your medications and your cardiovascular health, please share it with someone you care about. A spouse, a parent, a friend who is managing similar questions. Because information shared is risk reduced. Leave a comment below. Tell me, how many medications are you currently taking daily? And has anyone ever reviewed that full list together with you? I read every comment. Your responses shape what we cover next. Subscribe to Heart Truth After 60 if you want to keep having conversations like this one. And in our next video, I'm going to address something that very few cardiologists talk about openly. The blood pressure numbers that look acceptable on paper, but that cardiologists privately consider warning signs in adults over 70. Numbers that fall inside the normal range on your lab report, but that tell a very different story when interpreted in the context of your age and arterial health. That is a conversation that could change how you and your doctor approach your blood pressure management going forward. Don't miss it. Take care of that heart. It's the only one you have, and it still has a great deal of living to do.